You are welcome to the first session of this day, the molecular imaging session. I have the great honor and the pleasure to introduce Dr. PATRIK ZAMECNIK, Professor of Radiology at the Radboud University Medical Center in Nijmegen, the Netherlands, and he is also the Vice Chair Prostate MR Reference Center in Radiology Department, as well as the Scientific Advisor to SLPL Medical BV. His presentation will be an update on molecular prostate imaging, PSMA scan, and Nano-MRI. I think it will be a very interesting topic to be presented. Please, the floor is yours.
So, good morning, everybody. Thank you very much for the invitation to be here and to have the possibility to talk about, I think, very important and very innovative thing on prostate cancer imaging. We will talk not about the primary staging or the prostate detection and differentiation. We will talk about metastasis management, metastasis imaging. I will start with Nano-MRI. Maybe somebody of you already heard something about it. It's very easy. It's a normal MRI which is enhanced with an intravenous iron-based contrast media called thermoxran 10, which is the ENN name. The class of remedies is called USPIO, ultra small particles iron oxide, and the former producers called the Combidex of Cinerem, and the actual name is Ferrotran. You can see here the molecule of it. The blue core is iron oxide, and these chaotic molecules are dextranes, which is basically a glucose polymer. How does it work? Mechanism of action. So the solution of Ferrotran or Ferromoxtran is given by a slow infusion intravenously. The particles are distributing through the bloodstream in the whole body. You have to wait approximately 24 to 36 hours after the intravenous injection. And then what is happening, the macrophages are catching up these nanoparticles in the peripheral blood and are transporting them into it is very important, a healthy part of the lymphatic system, healthy part of the lymph node. Like this. And what we can get is, you can see here the lymph node. This gray stuff is a small micrometastasis, partial metastasis. To be honest, this is the very often situation in a prostate cancer that you have a mostly partially metastasis in your lymph nodes. And the dark gray is the fact that the healthy part of the lymph nodes, which is fully loaded with macrophages, which are fully loaded with nanoparticles with iron oxide. And if you are making MRI, what is happening? Iron is making artifact. So we will have in the normal part of the lymph node no signal. So it is some kind of negative contrast. So we are normally using fat saturated sequences. So the normal part of the lymph node is black. The fat behind it is also black. It's not always like that. You can also use without fat sat, but it's easier sometimes. And everything what is left, white spot, is a metastasis. Why it is so interesting? Because MR have very high resolution, so we are able to, with the normal commercially available sequences on 3 Tesla, to use a sequence which is giving you a resolution about 730 micrometers isotropic in vivo, so 730 micrometers voxel size, and therefore we can see in a daily routine metastasis down to 2 millimeters diameter without any problems, which is, to my knowledge, not available or not possible to achieve with any other imaging method at the moment. A couple of examples. This is a it's a T2 star weighted gradient echo sequence, nothing special, no work in progress, normal commercial sequence. You see here the iliaca externa, you see 2 lymph nodes, this one and this one, patient with prostate cancer. The question was, is there any metastasis, yes or no? Of course, we cannot see any changes in the sequence. After injection, after 24 to 36 hours, you see what is happening. This lymph node turned completely black, and this lymph node is getting such a rim black rim with a white center. The black part on this image, this is completely fully loaded with macrophages iron. So this is normal. This lymph node is normal. And this lymph node has a central metastasis. And if you don't believe me, we made a histology. This is the histology part of this lymph node. You see, this is normal, and this was a central metastasis. So you can see that if you're using high-result sequences, you can actually look on the microanatomy of the lymph node, and you can, there's a diameter like 2.5 millimeters, something like that. And you can do it with a very high sensitivity and specificity. We will talk about it a bit later. Another example. There's a lymph node also in a fossa obturatoria de facto. You see on the native sequence that the lymph node is very irregular, diameter about 7-8 millimeters. And after ferromoxan injection, after 24 to 36 hours, you see that all the lymph nodes turn black, but in the center is a very small white spot. And what was it in the histology? It was a metastasis. So if you have a good quality, if you have a high-result sequence, you have no moving artifacts, if you have a good uptake, you can detect. In this case, we were a bit lucky. 1 millimeter is really on the edge because you have a resolution of 730 micrometers, but 2 millimeters is that what we see de facto every day. Another example, you see here also lymph node, all patients with prostate cancer, of course, irregular lymph node. The question was, is an extranodal disease, yes or no? You see the effect. This part, the black rim, is a normal one, and everything what is left is beautiful to see extranodal disease, extranodal growth of the metastasis. But last but not least, another internal iliac node, precisely the same. You see that here, this is the normal follicular structure, and here a metastasis is growing. Why it is important, especially in prostate cancer patients, because you have a lot of partial metastasis in these patients. It's one of the reasons why we have that very high recurrence rate, especially after surgery, because the PLND is also not able to remove all lymph nodes which are potentially suspect. So a lot of patients which have even PSA of 0 have a lot of micrometastasis in the lymph nodes, sized 1-2 millimeters. Then of course they have sometimes to need to grow and to produce enough PSA to be detected. So a couple of statistics. The pool sensitivity in a lot of studies in the last more than 15 years was about 88%. And specificity about 93%. This is also something what you can achieve with a normal clinical routine, of course, if you are trained. So this is something new, and you have to be thought in this technology, and then you can achieve these results also without any problem. What's the current status of the project? We have 2 sites in Europe where is it available for clinical means for every patient which is coming with prostate cancer, and the question is, are there any lymph node metastases, yes or no? It's in Nijmegen and in Switzerland, in Zurich. We are now in the middle of the registration trial in Europe, which is taking place in Netherlands, Germany, Switzerland, and Belgium. And we expect the registration to achieve the registration in Europe about 2025. But already at the moment is available for all scientific studies in the whole world. So if there is an ethical committee approval, the company can deliver it for scientific purposes. And now a couple of words about PSMA-PET-CT, what's new. Just very short remembering of what is all about a PSMA. As a prostatic-specific membrane antigen, and the PSMA the expression is increased in higher grade tumors, metastatic disease, of course, even hormone refractory prostate cancer. And it started actually with scintigraphy, with ProstaScint many years ago. And the base of it is that normally the PSMA expression increase with tumor grade. But this is not fully true. This is true for approximately 80% of the patients. For example, in our center, we have up to 20% of patients which are PSMA negative. To be honest, on the other hand, we have a very highly selected patient collective, so this is not really, if you are taking people from the street, it will be not like that, but if you are a center specialized in prostate cancer, you will see that the amount of PSMA negative, especially metastasis, is not that low. In the literature, it varies about 5 to 15%. Again, it's dependent on the patient probe. And why we are doing PSMA at all, this is a very nice example. This is a bone scintigraphy with technetium, and this is the PSMA of the same patient. We know that scintigraphy is de facto very simple and good available technique. However, we are already living in the third decade of 21st century. We have to find a way how to bring the technique further, and to be honest, for this kind of patients, is scintigraphy no more responsible to do, because you are really missing things which are no more acceptable, I think, in our times. There are a lot of different PSMA ligands. There are a couple of companies. You see here the 4 most important ones, which are already registered or are in the process of registration. So it is not only the first one is a PSMA-11, which started in Heidelberg in Germany many years ago, like 20 years ago already, with gallium, labeled gallium. Now, of course, to make it cheaper and more accessible, the most of the companies are trying to couple it on the fluorine. Very important is especially this one and this one. Those are the 2 very new PSMA ligands. I will talk about it a bit later. For primary staging, there's a lot of literature available already. Again, the technique is not that new. It's already 20 years ago for the first PSMA scan in German Cancer Research Center in Heidelberg, where it was developed. The most of the publications are like that. They are, for example, this is a pretty recent publication from Hoffman from Australia, where he say the diagnostic accuracy is about 92% versus conventional imaging, it means scintigraphy and CT MRI, 65%. Sensitivity about 85%, and specificity is always relatively high. But on the other hand, for example, this one, which is much more detailed analysis. This is an piflufolastat PSMA ligand, which is now on the development, so to say. And in this graphic, you can see here, this is the sensitivity if you are looking on lymph nodes, for pelvic lymph nodes, which are bigger than 5 millimeters. Sensitivity is about 60%. It's not that high, actually, no? And if you're looking here, this is for all pelvic lymph nodes, so without the criterion of size. The sensitivity is dramatically dropping to 38%. I mean, this is very important because we are talking about technique which should tell us if the patient has metastasis or not, which is, of course, the most important prognostic factor. Why it is so? You have the first hint here. Then the bigger lymph nodes are better to detect with this technique than the smaller ones, no? Because here in this analysis you have all pelvic lymph nodes, including the very small ones. And prostate cancer, and I will show you later, is typical with a lot of, but a very small lymph node metastasis. PSMA is absolutely necessary for any kind of recurrence, to make it short. The results are very good. You can use it for local staging in case of recurrence, in case of biochemical recurrence, for a lymph node, and of course for bones. This is the PSMA-11. Very nice results. If you see, of course, the higher the PSA, the higher the detection rate, which is understandable. The same with the newer ones. So this is stable. So all the ligands you have, they have approximately the same performance in recurrent situation. What we already did, we are talking about Nano-MRI and PSMA. So what happened if we will compare these two techniques in order to understand what is the performance in detection of lymph node metastasis in the pelvis in prostate cancer. We did it. This is the first retrospective study. Now the prospective one is at the moment under review. What we did, we found like 197 lymph nodes which were suspected. All patients were getting Nano-MRI and PSMA. And then we just looked what is the number of positive lymph nodes detected in these patients by each method, by Nano-MRI and by PSMA. What came out that Nano-MRI can detect more suspicious lymph nodes comparing with PSMA, and these lymph nodes are even significantly smaller. Why it is so? It's easy because about physics. If you are using sequences with that very high resolution and the mechanism of action which I was describing in starting this lecture, PSMA is depending on other things, not only the expression of the PSMA but also on the hardware. And if the primary physical detection size, voxel of your crystal of a detector is 4 millimeters, then you can imagine that even with interpolation, your sensitivity for small lymph nodes it's lower. And that is what I was showing in the graphics. So this is a problem. It's a problem only then if you are not aware of it. So every method has some limits, and our job as a researchers is to show which method is suitable for which situation. This is a very recent press release which was actually published in the RSNA, last RSNA in Chicago. Blue Earth is a Bracco company. You know Bracco is a contrast media company from Italy. And they made a phase 3 trial, and the overall sensitivity with prostate cancer patient was 24%. Why it is so? Not because PSMA is bad and we should not do it. This is not true. It's because you will get a significant portion of small lymph nodes in your collective. So it is really dependent on patients you have. And why it is so? Because it's already known, many years known, that up to 68% of all positive lymph nodes in a general collective of metastatic patients with prostate cancer are smaller than 5 millimeters. And this is the reason. This is the oncologic reality, and this is what you have to have in mind if you are choosing or have the possibility to choose the right method for environment diagnostic, for lymph node diagnostic in this kind of patients. So we have to, as the imagers, also have to mind what we are dealing with. And in this case, the biology of the tumor is the most important things. Again, this is the reason why PSMA have, in some cases, in some studies, it depends on study design or your patient collective. And of course, it's also the reason why we have that many recurrences after surgery, up to 40%, because of this. Because we are not able to detect and to remove small lymph nodes, which are then growing slowly over months and years. So, conclusions. Nano-MRI is very highly sensitive, highly specific tool for pelvic lymph node metastasis down to 2 millimeters. It's very useful in case of biochemical recurrence. To be honest, most of the patients are coming to our center with such a diagnosis, so after mostly after prostatectomy, lymphadenectomy, and or radiation therapy, where you can detect even very small lymph nodes, especially as the PSA is very low. So from 0.1, you will find something mostly. What we didn't have that much time to elucidate is the iron-based contrast is giving you very fantastic angiographic images of high-grade diagnostic quality. This is of course not about prostate cancer, but is helping you to identify the precise localization of the lymph node for targeted surgery, for radiation therapy planning, etc., etc. And have an excellent safety profile. It was actually developed very, very originally 30 years ago as a remedy for patients which were, as a suppletion therapy for iron deficient patients which were on dialysis. So that's why there are absolutely no restriction regarding kidney function. We have regularly also kidney transplant patients, no problem. PSMA-PET-CT is to be honest, a standard tool for staging an intermediate and high-risk prostate cancer patients. Why? Because this patient can also have a bone metastasis. And in this case, is PSMA really the best tool that we have at the moment. For biochemical recurrence, the sensitivity is a bit lower, but still very high. So from 0.2 nanogram per milliliters, you can normally find some deposits locally or in the bones or in lymph nodes. It's perfect, as I show you the image with the scintigram and PSMA. Is very good suitable for monitoring of metastatic patients if you are getting systemic therapy. And because of biological and physical reasons and the construction of the physical principle of PET, is a bit lower sensitivity for very small lymph nodes. So this is important to have in mind. Of course, Nano-MRI is not that available. We hope that in 2 years it will be available everywhere. But even then, you have to in mind that this is a real, seems to be a real, not a problem. It's a limitation which we have to know. I would say it like that. Thank you very much for your attention.
Thank you very much, Professor ZAMECNIK, for your interesting presentation, and hope by 2025 we have the Nano-MR agent, contrast agent, will be available and in the market. And now I think we'll postpone discussion.